Hello everyone, this is Mark LaBarbera. This video is going to be on EKGs and cardiac blood flow. This video is primarily for Nursing 214 students for a 2-year nursing program where we don't get an awful lot of EKG practice or quite as much cardiac as I would like. So this video goes a little more in depth, covers some stuff that we've already learned in class, and adds to it significantly. A lot of this video is on ECGs, some 12-lead stuff, and at the end some blood flow stuff and some interesting stuff you can do with the blood flow of the heart. This video is for educational purposes only. It's not intended to be medical advice. Always consult your faculty when you have questions about any numbers or situations that this video might present. Medical understanding is always changing, so what's accurate today may be vastly different after the next study tomorrow. So who was Wilhelm Enthoven? This gentleman was the pioneer, the father of modern EKGs. He worked in the late 1800s, and here you see Enthoven hooked up to his string galvanometer, and what this is 3 buckets of salt water with wires coming out of them going into the string galvanometer. There's a thin piece of silver wire stretched across through a magnet, and it would fluctuate. The silver string would fluctuate as it picked up Enthoven's heartbeat. If you take a focused beam of light, shine it across this silver string, it'll produce kind of a bouncing rhythm on the wall. And if you put a piece of photographic film or photographic paper in front of it and move that along at a regular speed, you'll get what we see today as a normal kind of QRS wave. Augustus Waller and his dog Jimmy. Notice Jimmy's also standing in 3 pots of salt water. Augustus Waller originally kind of came up with this idea that if you looked real closely, you could find some kind of electrical energy coming out of humans and animals. But Waller didn't think there was any real medical use for this, so he never went forward with creating the EKG machine. But interesting that Enthoven had talked to Waller, and this is why Enthoven developed the EKG. It was all because of Waller and his dog Jimmy. So what's an EKG? ECG or EKG. EKG, because Enthoven was German, the cardiogram is spelled with a K. In English, we spell it with a C. I tend to use the ECG just because we're English. We speak English in America. But either way is correct. There's no real difference other than the English versus German spelling of cardiogram. So this is an outline of the heart. It has the conduction system already drawn in. You have the SA node up at the right atrium going down to the SA node, bundle of His, and down through into the bundle branches and Purkinje fibers. Now this continuously pumps out electrical impulses that we can capture either with buckets of salt water, or we can put EKG patches on like this. And this is a typical 3-lead, minimum number that you can really have to monitor an EKG with. And they're color-coded and usually labeled right arm, and left leg. So these measure, we're always referencing the positive electrode. In this case, it'll be either the left arm or left leg. the right arm is the negative electrode of the ground. And what we're looking for is the movement of electricity towards or away from the positive electrode, and that'll give us either a positive or negative deflection on the EKG. So if you think about a typical normal healthy heart, the impulse starts at the SA node, goes to the impulse starts at the SA node, goes down to the AV node through the bundles and into the ventricles. So you get kind of an electrical vector like that. And this is kind of a mean electrical vector because there's little vectors going off left and right and backwards and forwards, but most of the energy is going down in the direction of this arrow. It's going right towards the left leg. And if you reference the right arm to left leg, that ends up being lead 2, which in our program is what we've been looking at for the most part, because that's the one that's going to have the biggest deflection normally, unless you have some serious problems with the heart. Now, I said something about lead 2. On the left here is what we call Enthoven's triangle, and that's the 3 leads that we saw on the previous page. And right arm to left arm is lead 1, as it's labeled. Right arm to left leg is lead 2, and left arm to left leg is lead 3. And these give you different views of the heart somewhat from what you can get on the limb leads. These are called limb leads. If you look on the right, you have the heart with a bunch of lines drawn over it and some coordinates around the circle. We can tell what the average vector is by looking at this. And that's telling because we can tell disease processes, and this is kind of called the axis also. So normal axis is about -30 to +90. So if we get a very tall wave in lead 2, taller than any other of the limb leads, we can say that it's probably around 60 degrees or so. That's normal. If you get a very low amplitude, it might be more towards 0 or more towards 90. I've even seen some EKGs where the T wave, and we're usually looking at T wave with the axis. I've seen some that are extreme, where they're negative 120. Also, as we're looking at this, if you have a QRS that if you have the vector that's going like 120, that's almost exactly opposite lead 2. So if you get electrical impulse that is exactly perpendicular to the lead you're looking at, you'll actually have a very low amplitude or even a flat line phenomenon happen. If you get into advanced ACLS type stuff and you see a systole in your lead, they always tell you to look at a couple other leads as well, because of this kind of phenomena where you can have lead 2 that looks completely flatline, where 3 has huge spikes in it, just because you just happen to be looking at an exact perpendicular axis to where the energy is going. Parts of the QRS. This is going way back to the beginning. We have the P, the Q, the R up top there, S back at the bottom. The J point. J point's where the S wave turns to the T wave. And the graphic in black isn't real accurate. It's kind of a simplified version of what a QRS looks like. T wave and U wave. And I'll explain all these in a little bit. So the PRI, PR interval, is important. Too short, you have problems. Too long, you have problems. So PRI should be 0.12 to 0.2 seconds. Next, you look at the QRS duration, and that should be less than 0.02, or one large box. And so I was talking about the J point and the T wave in MIs, in myocardial ischemia, chest pain. A lot of times we'll look at the T wave as a way of telling, is there ischemia injury going on within the heart. And you'll see T wave elevation. And in gray here you see this kind of big T wave bumping up from the baseline. And you measure that from the J point, and you go from the J point up to the top and have millimeters of elevation for the T wave. If that gray T wave was a real T wave, I'd be kind of worried, because that's a pretty big elevation there. U wave, something that we haven't talked about, because it's real iffy on exactly what the significance is. It might be repolarization of the Purkinje fibers. It might be some electrolyte imbalances, but no one has a real consistent talk on exactly what the U wave is. It just kind of happens there sometimes. You may have one yourself, and it'll come and go. It may be related to stress, but it's hard to say exactly why and what that is. So they don't really teach it, especially in our very basic class that we have. Some variations in the QRS. At the top, going down, we have the delta wave of Wolff-Parkinson-White. Wolff-Parkinson-White is a accessory pathway problem where some people are born with extra conduction pathway going from the atrium down to the ventricles, which is okay, although this pathway sometimes allows for retrograde impulses, where the atrium will fire, will get onto the ventricles will fire, and then it'll come back up this bundle of Kent and come back up into the atrium and then start circling around on a nonstop loop. And this will produce like a very fast tachycardia that has to be treated a certain way, because it's not true ventricular tachycardia. It's Wolff-Parkinson-White syndrome. Very similar to that is LGL, or Lohn-Ganong-Levin, which is a bundle of Kent, which is another accessory pathway, does kind of the same thing. Bundle of Kent has a very close PRI piece, almost in the R wave. Not that you're going to be ever tested on this or need to know this, but it's interesting. If you see someone, you can kind of look for this. Next one down is the digitalis effect. It looks kind of like a reverse check mark, and you'll see this in patients that are on digitalis or digoxin. The Osborne wave of hypothermia, and you'll see this sometimes if you have someone that either has therapeutic hypothermia or has been out in the cold and has a lowered body temperature. You may see this in some leads. And the RR prime, sometimes they call it bunny ears. This isn't really indicative of a lot. Maybe the ventricles are firing a little bit at different times, or there's two firings within one complex. But maybe important to write this out, to show this in RR prime. We show on the right here at the bottom the little r, because first is a small r, and there's a large R, and the large R is bigger, so it has a little prime tick above it. Here's a typical 12 lead that would be printed out from a Hewlett-Packard 12 lead machine, which most hospitals use. So we have on the left side leads 1, 2, and 3 going down, then going back to the top, just under where it says 12 lead, AVR, AVL, AVF, and then farther to the right, V1, 2, 3, and 4, 5, 6 at the far right. At the bottom is a lead 2 rhythm strip. That's because each of these leads only has 3 or 4 complexes to it, and if you want to see how the heart changes over a period. If there's any arrhythmias or slowing or speeding up, you need to look at a few seconds at a time. So the bottom is the rhythm strip, so you can see if there's any change in P wave or PRI intervals. If there's like a PVC or PAC or something like that, you'll be able to see it in the rhythm strip. So we've already gone over 1, 2, and 3, which is covered in Enthoven's triangle earlier. AVR, AVL, and AVF is kind of a combination of 1, 2, and 3. Augmentation voltage right, augmentation voltage left, and augmentation voltage foot. So you still have the right, left, and foot, but they're reference to the two other leads, both cut in half. So the camera has kind of if you think about the positive EKG lead as a camera, the camera has kind of like a wide-angle lens looking at the heart. AVR doesn't tell us an awful lot. It's one kind of oddball lead. It's usually just about opposite of lead 2. It's inverted upside down. Don't worry too much about it. It's used for some advanced cardiology stuff. AVL and AVF, just different views of the heart. We'll get to that in a little bit. And V1 through V6 are the chest leads. Those are the ones that go across the chest when you're doing a 12-lead EKG. And those are thought of as taking a camera and taking a picture through the chest to the back, and then moving it all the way around to the left side of the chest and getting a good view of the front and side of the heart. So here's placement of the 12 leads. Measuring placement is actually kind of important. I have seen some people just kind of get them approximately on the chest about where they should go, but they don't actually measure. And when I've been teaching this, my fear is that we don't place them correctly. Say I'm at work and the ambulance, we don't place them correctly. We get into the hospital does their 12 lead, and maybe a ED provider or someone will look at it and say, okay, the EMS looks okay, ours looks okay, but you get someone that knows something about EKGs, and they're going to start looking. A cardiologist is going to look at this and say, no, the vector's off. How did this vector change, or why do these two EKGs look different? And they have 5 of them that look one way because someone measured, and one of them looks different, and they're going to throw the one that looks different out. And your work recording this EKG is going to get thrown away. So please measure where you put your 12 leads. Not everyone does, but really you're supposed to. So V1 in red, fourth intercostal space, right sternal border. V2, fourth intercostal space, left sternal border, this yellow. V3 is green, midway between V2 and V4. V4 is fifth intercostal space, mid-clavicular line. V5 is fifth intercostal space, anterior axillary line, and V6 is all the way around the side, fifth intercostal space, mid-axillary line. Make sure you measure these out. This is a typical left-sided EKG. This is the one that most people do. If you suspect that there is a right-sided heart problem, you can reverse these, and instead of V2 being on the right, you put V1 there. Where V1 is right now, you'd put V2, and then V3 and V4, and so on, over on the right side. And usually we only go up to 4 on the right side. That gives us a good enough view of the heart without going all the way to 5 and 6. You can likewise continue on posteriorly and do, if you believe that there's like a posterior MI going on, we're having some mirror image stuff coming through the front of the heart. You can say, you know what, I think this is kind of a mirror image because they're looking through the heart and the stuff's going on in the back of the heart. You could even take all the V leads, uh, put V1 next to V6, and go back up the back and get a look at the back side of the heart, which is done rarely, maybe in a cardiology office. But it's something to think about. You know, if you come across a posterior or right-sided 12 lead, that's what's going on. They're read pretty much the same. You just have to kind of remember where the leads are and kind of what you're looking at, because they're going to look a little bit different from what you're used to if you really get in tune with what the EKG is showing you. Another 12 lead here. Again, V1, 2, or 1, 2, 3, AVR, AVL, AVF, 1, 2, 3, and 4, 5, 6 for the V leads. So we'll go on to ST segments. And like I said earlier, this is where we're kind of looking for injury and infarct. You want to find the baseline of the rhythm, and in this one it's pretty clear. The baseline is right there in that red line. Sometimes if you have a lot of artifact or the patient's moving a lot, it can be a little more difficult to find the baseline. And this time is when you'll get a EKG, it's not quite right, and the provider wants you to try again to try to get it more to baseline, so it's a little easier to read and measure, because you're actually measuring the height of these ST segments. To diagnose a ST elevation, the ST elevation needs to be evident in 2 contiguous leads to be significant. And in this one, it looks like 2, 3, and AVF have elevation, and maybe V2 and V3, maybe V4, 4 and 5 and 6. So this guy's has something going on. But this is what elevation looks like. So ischemia versus injury. Ischemia, we see ST depression that goes below the baseline. And this is the first signs where the heart's starting to lose good oxygenated blood flow. It may just be kind of a narrowing, it may be a spasm of the coronary artery, and you're getting some reduction in the heart's starting to starve for oxygen, but hasn't got to the point where it's at risk of dying. Injury, the typical injury pattern is the ST elevation, and as you see here, V2, 3, 4, and 5 all have significant elevation. They're big. This is almost what we call a tombstone. This guy needs help pretty quick before something bad happens. Infarct, after you have this elevation, this is where you have actual tissue death, and you get large Qs. And these Qs we call the footprint of the MI. These stay there and they're there forever. The Q wave has to be greater than 1/3 of the total height of the QRS in that lead. So especially lead 3, that's a huge Q. This is different from a non-pathologic Q that you'd see in children. You might see in some young adults where you have small Qs. That's normal. A large Q like you see here in the lower left tells you that this guy has had an MI at some point. It may have happened last week. It may have happened 6 years ago. You don't know the timing. And not all MIs will have a Q wave. Not all MIs will have ST elevation. But if you do see a big Q wave like that, you can be fairly confident that this person has a significant cardiac history, whether they remember they have one or not. Okay, coronary arteries. Here we're looking at the, over on the left-hand side, we're looking at the right coronary artery, or the RCA. Um, any problems with blood flow there is evident in leads 2, 3, and AVF. And don't worry about writing this stuff down. It'll come into play in a couple of slides. We'll get you a trick to learn how to recognize this. So right coronary artery, 2, 3, and AVF. Left circumflex, that's coming from the left side and going around to the back and down. That's leads 1 and AVL. And left anterior descending, or LAD, that's coming around and down the front of the heart, and that's the V leads, V1 through V6. Those are the chest leads. And septal, if you see septal changes, you're usually talking about V1 and V2 for the septum between the ventricles. Okay, so here's a trick that I was taught in a seminar a few years ago. You take your typical 12 lead. You don't look at the rhythm strip at the very bottom, because it's not part of this. It's actually part of lead 2, which is in the left-hand side, or left-hand side in the middle. So you start off with the left main in the upper right-hand corner. You draw a line from the left main down through V4, 5, and 6, and up through V3, and that's your LAD. The top coming from that is the left main LM. Then you draw your septal off the left main through V1, V2, and then draw another line from the left main through to 1 and AVL, and then on the left-hand side you draw this separate RCA, right coronary artery, through 2, 3, and AVF. You don't have to actually draw this on your EKG. You can just kind of envision it, but it gives you an idea if you have ST elevation or depression, where it's coming from and what's causing it. If you have ST elevation in V3, V5, and V6, you have like a mid LAD occlusion. If you have 2, 3, and AVF elevation, you have a right coronary artery blockage, and so on. If you have, like a few slides ago, we saw this guy has, huge ST elevation throughout. What that might be is that he has a left main occlusion where he has V1 through V6 that are all occluded, maybe 1 in AVL as well. And that's where you have a high left main called the Widowmaker that's blocked off everything. Everything going to the left side of the heart has stopped moving because there's a huge clot there that needs to be taken care of immediately. Okay, this is another kind of depiction of what we were just looking at. Anterior is V1 through V6, inferior is 2, 3, and AVF, and lateral is 1 in AVL. And you'll hear people describe MI as anterior lateral or septal, something like that. And this kind of gives you an idea of how to follow that and how to use that type of language in your practice. The sequence of a clot formation and thrombus leading to myocardial ischemia. You get these plaques build up. As the plaques rupture, they release toxins into the blood that causes platelet aggregation. So these platelets start to build up to kind of form this clot because there's some kind of tissue damage and bad stuff getting into the bloodstream. And then this platelet formation breaks off, becomes a thrombus, and goes until it reaches a smaller vessel, sometimes in the coronary arteries, and then you get myocardial ischemia. And if blood flow is not recovered, you get myocardial death, and then that just kind of expands and builds on itself. anterior versus inferior symptoms. Um, this is kind of interesting. I highlighted the pulse and blood pressure increasing, along with the anxiousness, diaphoresis, increased respirations. For inferior, we have the same anxiousness, diaphoresis, but decreased pulse and blood pressure. And this will make more sense when we get to the graphic of it. Treatment of the MI, this is stuff that it changes all the time. These slides are a few years old, so don't take some of this may not be in the correct order, but aspirin, Plavix, nitrates, beta blockers, heparin are all still relevant treatments. So anterior versus inferior, and when we talk inferior, we're kind of talking the base of the heart, which is the right side of the heart, the low pressure side. And with inferior MIs, we don't want to give nitroglycerin or beta blockers. Remember a couple slides ago, I said that the pulse and the blood pressure goes down. If you give beta blockers, that's going to make the pulse and blood pressure go down even farther, and you don't want that because you need blood flow. So inferior MI, if you have 2-3 and AVF affected, hold off on nitro. These people need IV fluids. Nitroglycerin, you want to hold off on that because this will dilate the blood vessels. It'll dilate the venous return, and you're not going to get any blood flow to the heart, which will cause a problem because now when no blood flow can get to the right side of the heart, you can't get any oxygenated blood to go through to the left side of the heart, and you have a lot of problems. I've had patients with inferior MI that have been given nitro, and within 1 or 2 nitroglycerin given, they drop their blood pressure from 130 on 70 to like 60 on 40. They feel pretty terrible. They look shitty, and just pump fluid into them until they recover. Then we have to worry about problems with fluid overload, but it's better not to give them this if you recognize inferior MI beforehand. Getting into blood flow of the heart. So blood flow comes in from the venous side, superior inferior vena cava, into the right atrium, down through the right atrium, right ventricle, out through the pulmonary artery, into the lungs, back from the lungs into the pulmonary vein, into the left atrium, down through the left ventricle, and then pumped out to the body. So these arrows, I know there's a lot of them, but start with on the left-hand side and follow it through. There's a bunch of valves in there too. So getting a little more into that, look at the pressures of the heart here, and you don't really need to remember these pressures. We're not going to be tested on them, and these vary from book to book. But when you're looking at these pressures, you get kind of an idea that the right atrium here is 0 to 8 millimeters of mercury. 0 is almost just kind of like blood flowing in passively into filling the right atrium. It's not even being pushed anywhere. It's just kind of flowing in. Also remember that the heart is a 2-stage pump, as the atrium and the ventricle, that's side by side with another pump just like it. So the right side is a low pressure side. It's a little weaker, a little smaller. You start off with this pressure of 0 to 8 millimeters of mercury, just barely filling in the atrium. You get the electrical impulse that constricts the 2 atrium, pushes blood down through the tricuspid valve into the right ventricle, and diastolic pressure for the right ventricle has to be around that of the right atrium, so that right atrium can contract and push blood into the ventricle, and then when the ventricles contract, you get pressure of like 15 to 30 going out into the pulmonary artery. And that the arteries coming out of the heart will stretch a little bit. So you see diastolic in the right ventricle is 0 to 5. Diastolic in the pulmonary artery is 5 to 15 because of that little stretch. It kind of pushes it out, and that pulmonary artery kind of contracts a little bit as it's trying to relieve its stretch. That further helps kind of push this blood along. So 15 to 30 systolic, 5 to 15 diastolic, but it's just going to the lungs coming back. It doesn't have to circulate throughout the body, so it doesn't have to be under real high pressure. So it goes to the lungs, comes back through. Now that 15 to 30 systolic has been kicked down to 4 to 12 in the left atrium. So huge pressure decrease, but it has to go through all the capillary beds of the lungs. Through the mitral valve into the left ventricle, and here your pressures start building a little bit more. Diastolic for the left ventricle, of course, has to be similar to the right atrium, so the right atrium can push blood into the ventricle. When the left ventricle contracts, you get around 90 to 140 or so systolic that pushes blood out through the aortic valve into the aortic arch. The aortic arch kind of stretches out when that ventricle pumps and contracts after that initial wave of blood flow from the ventricle comes out, and you get your more typical peripheral blood pressure of 90 to 140 for a systolic and 60 to 90 for a diastolic. So I think that's really all I was going to talk about there, but it gives you a good idea of blood flow and pressures, and kind of reminds you about the pressures in the right versus the left side of the heart, which are kind of important and kind of remind you of what you're dealing with. While we're on the subject of pressures, a Swan-Ganz catheter. This is a catheter that gets put in through the venous system. It has a number of injection ports on it, has a thermistor to monitor temperature, has a distal balloon that you can blow up to monitor pressures. So this gets put in through the venous side of the heart, down through the right atrium. And if you look on the left-hand side of this picture, you see right atrial pressure, and this graphic says 0 to 8 millimeters of mercury. You see the amplitude is fairly low because there's not a lot of pressure change in there. Getting down to the right ventricle, you see a little bigger waveform at the bottom here because you're looking at possibly a 25 millimeters of mercury down to 6 millimeters of mercury at the bottom of this as a possible change for when it contracts and relaxes. Fish this down back up through the pulmonary artery, and you can get pressures up there and look at the waveform for the pressures up there. When you get into the smaller pulmonary arteries, you can inflate the distal balloon, and the pressure at which you completely occlude that vessel is the pulmonary capillary wedge pressure, and that gives you a good idea of how much pressure is actually going out through, or how much pressure is needed to perfuse through the pulmonary artery, which is about equal to what you're going to see coming back into the right atrium. So it's interesting. They can also do a cold water dilution where they put ice water at a certain temperature in through the Swan-Ganz, and then measure the temperature change distally as the water goes through, and it'll give you kind of a idea of blood flow, how much blood flow is getting through, and be diagnostic in that respect. Coming to the end, we have the coronary artery perfusion. On the left-hand side, you see the left main. On the right, you see the right coronary artery. What you're looking at is the aortic valve looking down from the aortic arch into the heart. And the aortic valve isn't quite closed all the way here, but on the right and left upper of the valve, you see two little exits that turn into these two large coronary arteries. This is important because the coronary arteries perfuse on diastole when the heart's at rest. So remember, if you can visualize it, the left atrium contracts, pushes the blood out through the aortic valve up into the aorta. It stretches the aorta out because it's pushing everything, and then as the aorta starts to contract back, blood starts to slosh back, closes the valve off, and now that pressurized blood gets pushed into the left main and RCA, and then out to the left anterior descending and circumflex artery. And this is an important part of the heart because now you get blood flow to the heart muscle itself, and it perfuses. If this doesn't happen, or if there's a big leak in the aortic valve, you're not going to get perfusion to the heart, and because you're not going to get that pressure, so you have to have a way of fixing that pretty rapidly, because within a few minutes of not getting blood flow to the heart's going to start to cause pain and then die. So one of the things we can do to treat this is inner aortic balloon pump, or IABP. So this is a catheter that's put up into the aorta, close to the aortic arch, and it's hooked up to an EKG. It's timed very specifically, and this balloon inflates and deflates very, very quickly, within milliseconds. And so it's timed, and they can adjust the timing and adjust the inflation deflation rates. On the left-hand side, you see systole, where blood's pumping out into the aorta. That arrow in the aorta shows the blood flow. The aortic valve is open. Some blood's pumping out, but maybe not enough, or there's a problem with leaking or the valve or something. In diastole, on the right, the valve closes, you start to get flow back, and this inner aortic balloon pump rapidly expands. And when it expands like that, it pushes blood back up and around and down towards the aortic valve and into the coronary arteries, and perfuses the heart. Next, systole, when the heart contracts, the balloon deflates very rapidly within a couple milliseconds and actually pulls blood up into the aorta because of this contraction and loss of this volume in the aorta very quickly. So that was my video for today. 2 recommended readings. I highly recommend Dale Dubin's Rapid Interpretation of EKGs. It's a fairly inexpensive book. It goes into the basics of EKG reading. If you go all the way through this book, and it's a very simple read, there's a lot of pictures in it. You go through this book, you'll be able to quickly diagnose all the basic rhythms that you're going to see. You'll be able to function in a telemetry unit after reading this. Other one is Bedside Cardiology by Henry Marriott. Marriott's a world-renowned cardiologist. This isn't so much about reading EKGs, but it's about the function of the heart and how to interpret it without an EKG machine, just using your hands and a stethoscope. And this is great for bedside cardiac stuff. If you want to feel for a pulse and figure out why the pulses are unequal from one side of the body to the other, why the pulse feels regular, irregular, stuff like that, why there's jugular venous pulsation. This book tells all about that. A little more expensive, still a good read, in a former program I was in. These are both were required reading, but highly recommended. I hope everyone learned something from this. My name is Mark LaBarbera. Please share this video. Look at the Medical Education Depot on Facebook. That's something I set up for more videos, and teach others if you learn something from this. Thank you. Have a good day.